we will start with our first talk by, I'm so old now, I have to look over my glasses, Dr. Jaafer Golzar, who will talk to us about duplex ultrasound technologies for pedal and tibial access.
Thank you so much for the introduction. My name is Jaafer Golzar. I'm an interventional cardiologist out of Chicago. So just by show of hands, how many of you guys are nurses, techs, work in the cath lab? Awesome. So I really want to thank Dr. Shishehbor and Dr. Banerjee for providing the grants. I actually brought one of our techs, Bindu Shah, one of our rock star techs, and really want to thank you guys for doing this. I think it's very innovative and really forward thinking, and you guys do so much for us, you know, make our lives better, make our cases better, especially when you don't roll your eyes when we ask you to prep the leg for pedal access. So that's what we're going to be talking about today is pedal access and kind of an algorithmic step-by-step approach, especially using ultrasound on getting access. And so you guys can play a pretty intricate role with this, with helping us prep the leg and kind of helping us with the ultrasound. It's not really that hard to learn, but it is a very important tool. Where's my little clicky thing? Important tool to know. These are my disclosures. So why use pedal artery access? So, you know, people think that it's this crazy, amazing, exotic technique, but, you know, I kind of think about it as kind of like the radial of the foot. It's, you know, back in the day, I remember back when I was in training, everybody was scared of doing radial interventions or radial access because they were like, no, you're going to, you know, hurt that artery and you shouldn't be accessing the radial arteries. And now it's, you know, common state of what we do. And so, but just because you get pedal access doesn't mean you're going to cross a lesion. You still got to cross a lesion. So it's just, you know, it's increasing your odds of being able to cross it sometime, antegrade, retrograde, and sort of connect the dots. I call it the finger of God as you kind of come together. And so why use alternative access? So, you know, there's the dorsalis pedis artery, there's the posterior tibial artery, and then what I call the final frontier, which is the peroneal artery. And we'll be talking about all of those. So, you know, it's really helpful in those cases where you have osteal SFA disease, where you have a stump occlusion. Back in the day, we would, you know, flip the patient over and do popliteal access. Well, that's kind of a pain in the butt because then you got to flip them back over or frog leg and stuff. So now we just do pedal access. So it's really helpful in those situations. It's also helpful when you have an occlusion at the level of a collateral because then the wire will keep going into these collaterals. So this is one of those that, you know, just start using it early. Like, don't wait, don't like use 10, 20 wires when you're trying to do this. When you'll know and be almost, you know, in 2 minutes that this is going to be a problem. Or when you just see this angiogram, you're going to be like, yeah, this is going to be an issue. So go ahead and prep the foot. And we usually try like maybe for a couple of minutes, and then if not, just go. Sometimes you get lucky. Then we'll go ahead and go retrograde. And this would be another, especially the popliteal artery, especially the popliteal. If you see this, like we just have a catheter up top and then we just immediately go retrograde because there's no way I'm going to get antegrade access because of those geniculate collaterals. So it's just best to go retrograde in these situations. So, ultrasound guided access. So this is really, really important to learn this. And there are some nuances to it, there are some nuances to pedal access. When you're kind of early on learning pedal access, and hopefully we'll be able to impart a little bit of my knowledge that I've had in my experience with tips and tricks. So the nice thing about ultrasound, there's no radiation, no contrast. You have a higher level of detail, because remember, you have the artery and you have two veins that sit next to it. So if you're trying to use fluoroscopic angiographic access, then it's kind of hard because you may be off just a little bit and may get into the vein. So that's why ultrasound is really nice. And you can also access an artery that doesn't have obvious angiographic blood flow. The disadvantage, there's only one, just experience level. And really that's it. So if you improve your experience level, then you should be able to get access pretty well. So just to kind of recap really quick, you know, the vessels below the knee, and it is important also to know what happens below the ankle with the pedal arch. So, you know, the dorsalis pedis artery connects with through the plantar arch with the lateral plantar artery, and that's what goes back into the posterior tibial artery retrograde. So in terms of ultrasound probes, so there's really a low megahertz probe, and that's usually what we use for femoral access. So the low megahertz probe, the nice thing about that is it has deep penetration, so it's great for femoral, but it doesn't have high resolution. So this is really what we use for femoral access, but really not good for pedal access. So for pedal access, you're going to use a high megahertz probe. So high megahertz probe, usually 16 to 20 megahertz. So that's the opposite of a low. So it's going to have low penetration, but it's going to have very high resolution. And so it's kind of good to learn how to do longitudinal, and this is just one of those things, just play with it, you know? Good to learn longitudinal as well as short axis. I usually get axis in short axis, but sometimes it's nice to see the wire traverse in long axis. And remember, with every artery, you're gonna have 2 veins. Now, if you don't see 2 veins with every artery, with that artery, it's not a true pedal artery, it's a collateral. So that's how you'll know the difference. So if you don't see a vein with the artery, 2 veins with the artery, that's a collateral branch that you're looking at, not the true pedal artery. So that's what the dorsalis pedis is gonna look like. It's gonna be the little circle in the middle and then 2 veins on each side. And then you can also kind of tell that as well as you compress, the veins will compress. Now, you can easily compress the dorsalis pedis artery, so don't like compress super duper hard. It's just, you'll just kind of know because those are the 2 next to it. Now, the posterior tibial artery will look like this. It's more of a like a little triangle or a V shape. Now, as you can tell, the ultrasound probe that I've put here, the easiest place to get access is going to be at the ankle strap, so right around the ankle. So that has the least amount of tissue, that has a little bit of a tethered, because there's a lot of tendons over there. So that's going to be your best bet, but you can get really access anywhere in that pedal artery. It just gets a little bit more difficult. And you'll have to use the lower megahertz probe. So this would be an example of what it would look like. I just did that just to kind of demonstrate where it would be, but we usually just do it under fluoro. And then this is the most important thing. Once you get access, so what we usually do is we put our needle in under fluoroscopic guidance, under ultrasound guidance. You wire it with a non-hydrophilic wire, and the reason that's important is because that's going to give you that tactile feedback. If you use a hydrophilic wire, you don't get the tactile feedback. The most important thing here is not dissecting the artery, because if you dissect it, just stop and come back another day. Don't even mess with it, because if you're going to dissect it, you're just going to screw things up even more and try to fix it and stuff. Just walk away from it, because all you're doing is dissecting it with the wire rather than putting it in a sheath. So the first thing I do is get my access. I'll put my non-hydrophilic wire that comes with it, make sure it's moving freely, and then I check it under fluoro, because I want to make sure it's moving freely under fluoroscopy. And so that's what we would do for the posterior tibial and the anterior tibial arteries. Same technique. Now for the peroneal artery, a little bit of a different game. So peroneal, I don't use ultrasound. Because the peroneal artery is much deeper, it's much more difficult to visualize. So here I am going to need to use fluoroscopic guidance. It is a little bit more challenging. And basically what you're going to do is you're going to just go orthogonal over and over and over and over until you get it. You're going to advance it, then you're going to go orthogonal. And usually these vessels are going to be pretty heavily calcified. And so really you're not going to necessarily need to keep doing angiograms. You can just follow the calcium. But sometimes if they're not heavily calcified, then you will just have to do injections. Unfortunately, it is what it is until you get access. So it takes maybe about 5 minutes or so. You kind of go, you just advance a little bit, you take a little shot, you keep going, then you go orthogonal, and then you'll really start to see, and then you'll kind of feel, or you'll even see that artery moving as you pop in.
You're approaching this medially, right?
Medial, yes, I have a shot of it for you, yeah. So here's a shot of it. So this is what it would look like under the ultrasound. So it hugs the fibula. So it's really, really close to the fibula under ultrasound, but that's pretty hard to see under ultrasound, especially if you don't have a lot of experience with ultrasound. I can't even look at that. I always ask my ultrasound tech, but we just use it under fluoroscopy. But this is what the peroneal artery looks like. So as you can tell, it's very deep in the compartment. So the other reason that's really important is because if you're going to get access and you're going to put in a sheath, then you better be sure you're going to cross that artery. Because if you don't, when you pull that out, then you're going to have a problem. And this could lead to compartment syndrome. So you're really going to need to be careful that you know that you're going to be able to cross this and you have the skills to cross it before you're going to approach doing peroneal retrograde access. So by hook or by crook, you better cross that lesion. Now, there are some things that you can do if you can't, for some reason, cross it, is you can put a blood pressure cuff on and really inflate that blood pressure cuff. The other thing is I never put in a sheath. I always stay low profile. So I'll use an 018 system, 018 quick cross or Trailblazer, and that'll be my access. I don't put in a 5-French sheath. And I never, I only give 2,000 of heparin on all of my cases. That's a CTO. I give 2,000 of heparin until I cross my CTO, then I'll fully anticoagulate. Because I don't want to be messing with a fully anticoagulated patient if I have a perforation or anything like that. So this is what it looks like, as you mentioned. So it's going to be medially, and it's going to be, and I go kind of distal third of the leg because that's less tissue there. If you're kind of going higher up, there's more tissue that you're going through. You're going to have to use a longer needle. So kind of distal third of the leg, medially, I kind of feel the fibula and then just kind of snake my way down until I hit that artery and just keep going back and forth until you get it orthogonally. There's my little animation I'm proud of there. So that's what it's going to look like. So here you see that calcium, you see the wire there, and it's a non-hydrophilic wire, and you want to make sure it's very, very free. And this was a peroneal CTO, pretty straightforward lesion there. So this is your toolkit. This is just a Cook pedal access kit. I don't really use a sheath. What I use is I use the dilator from the sheath to actually get access. So I'll put in my needle. I get my non-hydrophilic wire I put in. I take out my needle. Then I put in just the dilator of the sheath inside. And then I put my wire, like a V18 or whatever it is. Then I'll put in my quick cross, and then I stay bareback. So that's what my access technique would be. So this is a dorsalis pedis artery. I have my needle. I look at it. I try to line it up. And I'll kind of compress the veins just so I can see where the artery is and so that I don't hit the artery. And then I kind of tether my hand on the foot itself so I'm not moving a lot because it is a small artery as you're getting access. So I tether my hand on the foot so it's not moving very much as I gain access. And sometimes you go through and get it on the way back. So that's what it's going to look like. You're going to confirm wire position, as we mentioned before, and then move forward. So let's talk about some challenges, some tips and tricks for challenges. Probably one of the biggest challenges that you're going to see. Yes, sir.
Real quick.
Yes.
Do you prefer a transverse view of the vessel as opposed to a longitudinal view when you're putting your needle?
Yeah, so that's exactly right. So in the femoral, I like the long axis view. In the pedal axis, I like the short axis because of those veins that sit right next to it. Because sometimes it is so close to it that it's kind of hard to get access there.
Hey, Jaafer.
Yes, sir.
If you don't mind comment.
Yes.
So I like long axis if you can do it. Dorsalis pedis is very shallow, so typically you do short axis because by the time you see the needle, you're way past it. But if it's a deeper vessel like posterior tibial or peroneal, I use ultrasound. So I use the big peroneal. Usually, if your PT is 1 to 2 centimeters deep, the perineal is going to be 3 to 4. It's going to be double. And typically, like you said, calcified, I do a long axis. And the nice thing about long axis, if you can get the veins away from it, is you can see everything. You can see the needle penetrate, you can pass the wire and pass it up. So,
yeah.
And it depends.
Absolutely.
You can approach it anterolateral, like fluoroscopically, or you can go from posterior for a perineal.
Yeah. And like you were mentioning, so, don't be afraid to use higher tibial access. So you don't necessarily have to be, so for example, if I'm going to fix an SFA, I'm not going to stick the DP, I'm going to do a high AT stick to fix the SFA, just because you're going to be a little bit closer. So calcification. So a couple of tricks for the calcium. What's going to happen is it's going to start rolling around on you. So a couple of tricks that I have is you really puncture instead of slowly trying to get access. So you get right on top of it and then just pop it like a spear. That's so sometimes then you can get in. The other thing is tether it and really compress. You could actually, if you know you're right on top of the artery, compress the artery and hold it with your ultrasound probe, then pop through it and then release your ultrasound probe and then pull your needle back. That works. And then sometimes you just got to move your needle. Just find another spot. You can do that in the longitudinal view. That's really helpful to do it in that view, because then you can see the artery in different spots and you can get access. The other thing is shallow your needle a little bit more. So if you're more of an acute angle, it'll pop a little bit easier. Whereas if it's shallow, it just kind of like slowly glides in. So that's another technique, but that's probably gonna be the biggest challenge that you have, is gonna be calcium. And those are some tips and tricks to be able to get around it, and 95% of the time, that's gonna work. Hibernating vessel, this is pretty awesome for ultrasound because you're not gonna see flow by angiography, but you may say, oh, patient's got desert foot. You know, there's nothing to do, there's no targets distally, but put an ultrasound probe on there. And you may actually, and look, you're gonna have to look at it with duplex, so you may not actually even see color because there's just not enough flow. So just look at the vessel itself and see if it's occluded or not. And you could actually even, you know, this is not appropriate for this talk, but you can even get access to occluded pedal vessels if you need to. But that's where ultrasound could be very, very helpful. You can actually get access to a hibernating vessel. So in conclusion, pedal access should be routine part of your practice, not exotic. Get good enough for it to be a routine part of your practice. Access is key. Ultrasound guidance is the best. Use vasodilators beforehand. I'll usually get a retrograde access first or antegrade access, and then I'll give some nitroglycerin just to kind of plump up the vessels before. Use this technique and use it often. Thank you very much.
Thank you very much. That was a fantastic talk. I'm going to introduce now our next speaker, Dr. Arthur Lee, who is going to continue on this topic of retrograde access to talk about retrograde SFA, popliteal, and in-stent access.
Thank you. Yeah, and just to add to that, anybody who's early in their career or starting this, you know, a good place to get practice is in the femoral access. You know, just use it ultrasound all the time. Use it in long access. Venous ablations, you can practice on veins, same thing. Just get really comfortable with that ultrasound beam. All right, so just to move on with the same sort of motif, when we talk about some higher access. Share my disclosures. All right, so access in 2023 can mean a lot of different things, you know, and most of the time I'm doing tibial-pedal access. I would say greater than 97% of the time I'm doing tibial-pedal access for all my cases that I need retrograde access for. So it means ankle, you know, digital or lower even. But there is SFA and popliteal, and I think these are good options to keep and to think about for versatility. So again, like what Dr. Jaafer said, you know, the benefits of ultrasound, again, sometimes you don't have access to it, but so it's good to also know the fluoroscopic approach that he was talking about, but you know, I think ultimately you want to get adept with ultrasound. So I actually had cases on a jump drive on the way here, and I was going to put in new cases, and then I forgot my dongle. So I had to go into my old cases and find some stuff. So 68-year-old guy with short distance right calf claudication, had a history of a supera stent in the right distal SFA, sort of remotely, no wounds, but you know, Rutherford 3. Exercise ABI was performed. You can see the right leg drops. We did a duplex and runoff, and it showed basically osteal SFA, almost flush occlusion, with a distal supera stent and reconstitution P2 with the 2-vessel runoff and anterior tibial that was occluded. So again, these are pretty old, but you can see sort of what I'm talking about, a really big profunda. This was actually one of the first superas that I had dealt with when it occluded. Not bad tibials. So, you know, I think probably most of us would at least try from an antegrade approach. Any thoughts on how to approach this if it was flush occluded? Panel, anybody? Nick? Any tips?
Well, I mean, you're already close to a place where you can get your wire in with a little loop, and you can see if you can go all the way into that stent. Hopefully it won't go behind the stent, but at least it's worth a try, you know, at least via the antegrade approach, if you can. And if
then
you
what about at the very top, before I crossed here? If it's a flush occlusion SFA, what are you doing? What are the couple of steps to make sure it's flush for new guys? The orthogonal view, good? Good. Right. So I think that's what I was getting at. So take, you know, maybe at least two, maybe even three orthogonal views, because sometimes the vessel, you know, you'll see a nipple or something in another view. Sometimes you can look at the other side, because again, it's mostly symmetrical. Also, external ultrasound, just like when you got access, you can really see like a navicross catheter really well. You know, I use vertebral catheters because they're cheaper, but you can point right at it and really try to push on it. And so that's what we did. We got down here, and exactly what Dr. Seamus said is what happened. I kept going behind the stent here. I don't show it, but it kept going behind. I could not just get into it. So what's the next step you would do? potentially? What are my options? Good. So definitely could stick the posterior tibial, and again, I don't remember exactly why, but remember, this is a claudicant. Depending on where you practice and how comfortable you are, you don't want to, hurt the runoff vessels. So in this case, we're going to show you, this is an occluded stent, so it's not just a stent, it's also an occluded stent. So this is what we typically do now. If you're going to do under fluoroscopy, you typically go contralateral view about 30 degrees, because the vein is usually sitting behind it in the other direction. But ultimately, ultrasound is very easy here. You can see what it looks like, especially with a stent. It's nice and bright. You don't want to go too distal, because actually that artery can dive pretty deep, and you might not be able to reach as easily. Your angle of approach may end up being a lot more acute than you realize. But this is what it looks like. This is the needle. You can barely see, but the needle is here coming in. You can see here as the needle punctures, you're through. You can tell by ultrasound. Now remember, this is occluded, so I typically, even my tough pedal access, I actually use a V18. V18 goes in, and the nice thing about it is it breaks very quickly into a loop and can dissect up the artery, and typically these are occluded arteries. So this is where the wire is, confirming inside the stent. Here you can see I take a CXI 018, so I didn't put a sheath in. You can, but I just follow with a CXI. Put the wire into the vertebral catheter at the common femoral, exteriorize it, reverse everything, come down, balloon, and put stents in. And so again, nice result without having access to tibial vessel. Okay, one more case, 68-year-old man with SFA stents, I think it might have been bilaterally, but bottom line is had bilateral SFA occlusions, really short distance claudication. We had opened his right SFA. His left SFA had a very sort of high-grade stent fracture in the distal SFA. And so we talked to him about bypass. He really didn't want it, so we did medical therapy for over a year, I think. Eventually came back and just really wanted us to try something. So we basically said, okay, we'll give it a percutaneous approach. And sorry, I didn't have the diagnostic pictures here, so you have to trust me on the stent fracture. But this is what it looks like. What you can't see probably is there's a stent in the proximal SFA. It's not ostial. And then I just put one shot of the runoff, which is a pretty big perineal artery. So again, claudicant. And we talked about tips and tricks about how to try to get into the SFA. So it didn't work, okay? I couldn't get into the SFA, I couldn't get anything started. So again, the options are here, access the perineal artery, okay? But it's single vessel runoff in a claudicant. Access the popliteal artery, we've already talked about that. It can be a little cumbersome to flip them, et cetera, et cetera. You don't have to flip them, I'll show you later. So what I ended up doing here was I basically accessed the proximal SFA, so you can do distal SFA, but that's exactly where the stent fracture was. So I didn't really necessarily want to be in that stent fracture. I was thinking about excluding it or, going around it, basically. So what I did here in the third frame is I get access here in the proximal thigh, which is pretty easy. It's still pretty superficial. The prep is a lot easier because you just basically extend the prep down here, cut the drape a little bit, and then my wire actually went into, it went here, but it kept hitting. I couldn't get through the stent, so it took a subintimal approach around the stent, so I just kept it there. Eventually got through here, exteriorized, put the wire into the sheath. One technique I do once I put it into the sheath is I pass the wire, and then the sheath valve is here. So I basically take my short access sheath and I push it into the valve, and then I just watch the wire go through that check flow valve, and I pull that, and then I have the wire. Okay, so I exteriorize the wire, and now I reverse everything, and I basically bring my equipment down past this access point, which is right here, and go as far as I can. Now here, I ended up hitting another serial occlusion. Okay, here's where it reconstitutes. Sorry, it's not playing, but it reconstitutes here. So now I have to cross that, okay? The stent fracture, the stent actually ends right here. It reconstitutes literally right here. So I'm at the end of the stent. This is where the stent fracture is the worst. So again, I could access retrograde, but it's single vessel. Also, accessing retrograde, I probably either would have gone through the stent, or I would have gone subintimal. So chances of me crossing in the same subintimal plane, I think, are fairly low. So here, I actually used a reentry device, which again, I don't do a lot of, but I think it's still useful at times. So here's my reentry device. So again, if you're coming out of training, I think one of the categories of things to get really comfortable with is a reentry device, whether it's an Outback or Pioneer. I think the needle-based reentry is important for all kinds of stuff. So here we re-enter into the popliteal artery. And remember, I'm crossed now outside, so I'm inflating the balloon outside of the stent. up top and below, and this is what it looks like here after. So what I did is I took a supera and deployed it here, making a double barrel configuration. The supera is nice and strong where it'll crush the other stent enough to give you a lumen. And this is the result at the end. So sorry, I'm supposed to play all at the same time, but nice result. All right, so again, just an example of where SFA access potentially can help and make things easier. So popliteal access, there are ways to do this without flipping the patient. Again, I haven't done popliteal access in probably years now, because again, most of the time you don't need to. But one way to do it is sort of elevate the leg here, put a little crate under the ankle or something, and you can basically, take the probe as long as it's prepped and just hold it under the knee, and then just watch the screen and avoid the vein and literally do it like this. Once you get access, put a sheath and then just tape it to the front. So that's one way to do it. Another way to do it, which this is actually from Dr. Runback, but if you want to access the P3 segment, you can do it under a fluoroscopic guidance, or I do it under ultrasound in this area, but he did fluoroscopic, so he's basically following the landmark, and he's basically right on top of the calcium, puncturing in anterolateral fashion through the tibiofibular ligaments, and you can get it up that way. Another way in this area, just to bring it up, is high AT access. So high AT access is actually very easy to do. It's a very superficial artery at that point. This was actually a very good case, long case, but just to show you, there's really nothing below the knee except this little island. So again, I've only had to do this maybe twice, but it's very easy, very easily visualized by ultrasound. Poked this, eventually got up. I actually stuck perineal and was able to reconstruct the bifurcation and got him at least one good vessel. But the AT was occluded here anyway, so it's not like I'm going to hurt that vessel. And at the end, I balloon tamponade it just so I don't have any risk of compartment syndrome. So yeah. All right, those are other potential accesses.
Thank you very much, Dr. Lee. That was a great set of cases, and we'll move on to some more alternative access. Dr. Sayfo, radio to peripheral tips and tricks.
Thank you for having me. I was told it's a case presentation, not cases presentation, so I only have one. So we talked this morning about radial access and options, but with all honesty, if you're doing CLI below the knee, having radial access as your only access is not feasible. I think we still don't have the equipment. We have more and more coming, but what I want to present is a challenging case, and the radial access was helpful in one way. Is this my disclosures? So this is stand up here. So this is a 74-year-old gentleman, average BMI in Texas 40, recurrent occlusion of the left lower extremity with life-limiting claudication. He had a very busy history over the years. So first time he was seen by a vascular specialist was 3 years ago. He had a SFA stent, then went back for a popliteal trunk, pop TP trunk stenting, then had an AT stenting in the setting of a non-healing wound. When they did that, they excluded the ostium of the AT. He had recurrent occlusion, and at that time, he had a complication with the right groin after his third procedure and had a groin pseudoaneurysm required with thrombin injection. He got frustrated, had more symptoms, went back to the same physician. He told him he needed another procedure, so he decided to go to a different operator. So the other operator reviewed the films, and he told him that he needs an amputation. So he didn't like that, so he went to a third operator, and those are 3 different specialties, not in order. And at that time, he got 3 different interventions. So the first one, last year, he had a laser atherectomy with DCB. Then he had a repeat stenting of the TP trunk. So the TP trunk across the AT had 2 layers of stent at this point, going to the perineal. Then he came back maybe 8 months before I saw him with acute thrombosis, required thrombectomy, laser atherectomy, DCB, and had a complication from the groin during that procedure requiring surgical intervention. So the third operator, when this happened, now he has a flow. The flow goes to a perineal that end halfway in the leg. There's really no good outflow in that vessel, and that when we reviewed the case, we think that's why this arteries continue to close, plus the multi-layer stent. So the third operator asked for his second opinion. So this is what still frame to show you the last image from the last procedure. You can see the AT is occluded. The stents that were placed in the AT, they did not reach to the ostium of the AT. And the two-layer stent in the perineal to TP trunk runs to a perineal that doesn't have really good outflow. So the question is what to do. So these are the 5 different options that I thought about. Who would send the patient for amputation? This is his maybe 9th procedure so far. Okay, good. Amputation-free room, I like that. So what about bypass? Actually, for bypass, he didn't have a good target for bypass because his AT was occluded and only reconstituted at the ankle. So the surgeon thought it's not a good option. Integrate access from the ipsilateral and try to cross the double layer occlude AT or maybe open the PT. Contralateral access, remember he had 2 complications in the right groin recently requiring surgical intervention, or pedal access. So what we did with this one, we did a dual access technique. The right radial was helpful because you can deliver, first of all, you can take pictures, you can deliver some equipment there, but what you try to do is just use it for pictures, and we access at the ankle level, we access the AT, which was occluded, and we used an Astato with microcatheter, and you see on your right side, after multiple attempts, we're able to puncture those 2 layers of the stent and go through it. I don't know. I don't know the answer. We're down for a different institution. We don't have this record. The first one were not superior. The second layer was superior.
And does he have a wound, or I didn't hear, wound or claudication?
CLI.
Yes, okay.
Yeah. So we're using the Astato, we're able to cross, and we thought about just do a kissing balloon to get, so what we noted, we had to treat the AT, and we use an IVUS, and what you see is an undersized stent, non-prepared vessels, heavily calcified. There are 2 stents, actually there's a gap between them with an occlusion there. So we used a shockwave IVL therapy there, and then we did a kissing balloon, and we're hoping that will achieve what we wanted to achieve. It looked great till we pulled the wire back, and you can see the flow is really not great in the AT, so we know that's going to close. Perineal has not achieved enough flow to keep the stent open, so we elected at this point to proceed with stenting in that location, which is not favorable. But this is the final result we had in this patient. That's 6 months ago, so he's been 6 months free. Again, this is just a different way to achieve the same thing. So after we crossed, we stented from the distal popliteal to the AT, we rewired from the radial approach, and we did a kissing balloon there. This is in the cardiology called call-out technique for our vascular partners. When you go back with the stent, rewire, and you just do become heavy. In the proximal, you have 2 layers of the stent. So the question when I was asked to give this talk is tricks and tips about radial access, but it was under a critical limb ischemia segment, so I tried to get both together. So for radial to peripheral, there's a lot of question about using right radial versus left radial. We use right radial majority of the time just because it's easier to do in our cath lab, but with the left radial, you take 2 advantages. You get 10 to 15 centimeter of length in your catheter, plus you don't have to deal with the brachiocephalic tortuosity. The sheath length, we use 119 or 120 on majority of the patient, shorter than 6 feet. Anybody more than 6 feet, we use a longer one. If you're doing an iliac in a patient who between 5 and 6 feet, we use a 105. I think we start having more and more understanding which catheter to use on which patient. Depends on the patient height and the location. So I think it's very important to understand what do you have in your lab. If you, for example, for drug-coating balloon, we only have the Ranger that goes to 150 centimeter in shaft. Now Medtronic have the DCB, the 018, that's 200 over the wire, which was a game changer for us. Initially, when we did radial to peripheral, any young patient, we think you need DCB. We always went groin or pedal because it's not fair to put a stent if you can just do drug-coating balloon. Shockwave, it's M5 plus, that 135, so it reached to the common femoral, proximal SFA, and iliac. Wires, we still have a challenge with wires. So because you can cross with your preferred wire, but those wires go us to 300. The only long wires we have is the glide wire is a 400 035 and the Viper wire, which is 475 014. There's limitation there. Supporting catheter, the one available now is Viper catheter, which is one of the worst catheter you can ever use. It's not supportive. It has a plastic tip at the end. But now multiple companies, including the Sublime microcatheter that's going to come in the market, and other companies are working on it. So that's my last slide. So crossing the right brachiocephalic, it becomes challenging. So we usually use the 125 5-French GR4. We can do the vert. Also, pigtail actually very helpful. Every once in a while, out of our 260 cases, we had to reverse to the left radial or groin 5 times, just because of a very tortuous brachiocephalic. Wire delivery, we usually use a stiff wire. This is very important. If you try to use a glide wire or a soft wire, the sheath will not deliver all the way down. You don't have any resistance going in. And recognize when you have a prolapse in the ascending aorta. So when you try to push your sheath or your catheter or your balloon, and it just not crossing, but you feel some pushability going in, that more likely than not you're prolapsing higher up. Just go to the top. The only thing you need to do is just pull the catheter counterclock, and you will straighten it up. So this is our publication that we published in ACC and then in SCAI, and now we submitted to ACC. We'll see if it get accepted. Is a 200 for our first 200 patient of radial to peripheral. It's a single hospital experience, and it's looking at our 272 procedure, and majority of the lesion were SFA. Procedure success was 98.8%, and same discharge was 96%. This is 1 year follow-up so far. Looking at their classification, 72% of the patient has Rutherford classification of 0, where at baseline we had 31% were in class 3 and 45%, 45% were class 3 and 15% were class 4. So what to learn? I think CLI, we've learned today over all the talks, CLI is a very, very serious disease, and just offering patient amputation without looking at what options we have is not fair for the patient. It's not the right thing as an advocate for our patients. So all methods is available, and you just need to learn it and use it. Radial access can provide alternative pathway for support pedal approach instead of the other femoral access. But and as we know from coronary intervention, radial access has a lower risk of bleeding. So we're hoping, using the radial as adjunctive, and hopefully in the future may use it if we have the available equipment for below the knee intervention. Thank you.
Thank you very much, Dr. Sayfo. In the interest of time, I'm going to skip over Dr. Banerjee's talk. And as the media people are pulling up Dr. Younes' talk, I want to ask Dr. Kovard over there, and all this discussion about alternative access for these challenging cases, let's not forget that we are surgeons. And can you talk a little bit about times you might cut down on the axillary artery or the SFA, or other times you might want to consider a surgical approach as opposed to the endovascular acrobatics that we can do?
I was thinking about that during some of these talks, that I have a very low threshold to do brachial access for a lot of these types of cases. And I know some of my colleagues, either cardiology or vascular surgery, will do percutaneous brachial artery access. I don't do that just because I don't like the risk of that. I do a small cut down either just above the elbow, or if I need to go higher, I'll go into the axilla. I do that under local with sedation in the cath lab frequently, or if I'm in the operating room, it's obviously easier when they're asleep. But so I use surgical brachial access a lot because there's basically a lot of options once you can put a 8 French sheath in the brachial artery and not worry about closure issues. So I do that a lot.
Yes, thank you so much. I agree. Sometimes a primary cut down is so much easier than having to go back to fix it after it's a hematoma or thrombose.
It's good for mental health because you don't worry about it.
It's also good for the operator's mental health. Moving along, this is Dr. Younes, who's going to talk to us about building a community vascular practice.
Sounds good. Well, good afternoon. Well, shifting gears a little bit now from angiograms and access into building the vascular practice so you can get the patient to the table. This is my disclosures. The objectives today is just to go over how to build an referral base, importance of communication, data monitoring, resources, economics, mentors, marketing, and all in 8 minutes. So we'll make it happen. So if you make the patient as the center of your practice, the business will follow. And we keep that in mind as the center of the universe for our practice, and it will follow. Now, with the changing landscape of the healthcare system, it really depends where geographically you fall in the United States, and that will kind of shape your community vascular practice. If you're in an area where the hospital system have already consolidated into bigger system, hub and spoke model, that comes with benefits. I mean, it comes with challenges that are interdepartmental barriers you have to maneuver through the administration and politics, but it really takes away some of the challenges. You do have access to patients. You have access to resources if you are part of the system. Now, if you're not, this is the market that is the toughest to penetrate, especially if the system already have their own specialists that do what you're offering. Now, if you're a solo practitioner, that comes with another kind of challenges. This is less and less currently. However, if your referring physician is a solo practitioner, this is a great opportunity to connect with. If they survive the consolidation of the system, they usually don't have that much ties with what's around. Now, with the new move towards private equity affiliated practices, private practice groups, multi-specialty groups, that comes with a good amount of perks and resources. And usually the target market is typically you can start with the backyard, which is the cardiology group that you're working with. This has the wealth of patients. Now, important to understand the landscape, know the allies, know the competitors, really collaborate with everyone, collaborate with your competitors, create this culture of collaboration. There is too much disease that we can handle. There's too little of us, and we really have to collaborate to each other and keeping the patient in the center. Now, the medical practice is still traditional. It really relies on the handshake. Work with the physician services at your local institution, the groups, set up meetings and office visits, really have a landscape. I do have a landscape, a map, offices that I visited or I plan to visit, and that will funnel all the patients to your practice. When you're doing these visits or when you're doing these meetings, I think listen well, survey, inquire without really criticizing your competitors, but inquire what challenges they experience in their vascular care to the referring physicians. And they will tell you what they want. You know, they're not shy about verbalizing what they want to have from you. Satellite clinics, the days where we sit in our office and the patient would just funnel and come in, I think that they're behind us. Now we're gonna have to have the deliver care locally, either with clinics, ASCs, OBLs. One way to do it is if you're with a cardiology group, following where the most cardiology patient encounters are, where we know that up to 36% of patients with coronary disease, they have vascular disease. That's a place where we can align ourselves with, where there's a lot of cardiac patients, understanding the local case mix index and the payer mix is also important. Now, promote that new thing that you bring. Do not give promises you cannot keep. You know, if you do have already the infrastructure, that will be attractive. I will see your patient immediately. I will do the intervention early if needed. Another promise to send the patient back to them. You know, I'm not managing their wounds. If you're a podiatrist and you want to take care of the patient, the patient is going to be going back to you, and I will give you immediate feedback. An important thing I will still use is I'll send feedback to the referring. I'll send them images. They do like that. This is a case where we had retrograde PT and DP, and we revascularized the tibials. It takes usually one not so good experience for the referrals to slow down. Ask for feedback. Remember, rejections is actually an opportunity to improve. It's not, don't take it as setback. Now, we've all heard about the A's, availability, affability, and ability. It really takes more than that. You know, these are required, but that's not everything. I personally share my cell phone with the referring physicians, and I communicate with them directly without secretaries and office staff. Patient experience is important. I think Jim Gilmore from Case Western, he wrote a book about the experience economy. We're no more offering goods, we're no more offering services, we're offering the experience. So, and it starts from the office staff, the scheduler, the wait time on the procedure day, treat patient's anxiety. Patient will notice actually their access site, the discomfort, and importantly, the ability to call you back after they leave the procedure. You know, they don't see the stent expansion or the IVUS images. We do, but the patient they care about the experience that day. Have a close follow-up with them, otherwise someone else will. So in the early cases, don't be as aggressive. The goal is not to have any harm. Aim for 0 complications. They can and they will happen. Access site management is key. I still pull on my own sheath and put my TR bands, just we don't want any of. Now, the referring experience is, they're the client, and that's another level of experience that we have to keep it up to speed. We do collect data and we monitor them prospectively. Either I do it myself or we have someone who can keep track of that. And we do keep track of certain variables that are important to keep. The referral to appointment time to procedure day, the feedback, was it provided or not, the patient follow-up, HD catheters duration, and importantly, patient outcomes. I would keep same-day appointments or next-day appointments available all the time for urgent referrals. And the referring physician really appreciates that. Now, if the referrals at a certain center slows down, I think it's a good idea to inquire why. Not in an accusative way, but asking what can we do better. Recently, there was a dip from one of the referring centers. I called them. They were under the impression that I'm out of network. After one patient experienced, the patient was out of network. So these are things it's good to communicate and have a conversation. Be ready to make sacrifices, especially early on. There will be cases on holidays, even when they're not on call. Pick up the phone and just make it happen. This is a case who came from out of state, osteomyelitis, foot osteomyelitis, was taken on Thanksgiving Day, actually, occluded tibials, revascularized his tibials, plastered his plantars, he got his TMA, and now he's walking. So that's really, and that referring physician now refuses to refer to someone else. So resources, if there is an opportunity to have a program coordinator, that's great for the endovascular program or for a vascular program. That's not always feasible, especially these days. I have the scheduler on your speed dial and really collaborate with industry, the local reps, the local industry, to help you understand and navigate through the local landscape. Another cornerstone and really a building block for your vascular practice is the non-invasive vascular testing. It's critically important in my mind. It helps build with the referrals. It's really helpful for same-day testing, especially if patients are traveling from far. They don't need to come twice and it's easier access for patients. Now, one word about economics, because that's been talked about a lot today. Really, it's important to have an understanding of the economics of your practice, whether you're employed, whether you're private practice, whether you work in an ASC or an OBL. spending 5 to 6 hours to cross an SFA CTO is really not going to help your practice in the future. You know, it's no one would want to work with you in the lab. Don't be afraid of stage. Keep the ego behind. Stop and come back to tackle it. Now, for private practitioners, because I moved from academics to private practice now, and I'm in a hospital system that is private. For private practitioners that cover the hospitals, that take call and they go in and do procedures, there is a chance that we not be compensated for it if the patient is uninsured or is uncovered. The hospital may, through uncompensated care, through Medicare. So it's important to engage in a conversation with the hospital you cover to establish a fair professional service agreement that you at least get compensated for the efforts you're putting in there. Document well to reduce the burden of payment denial. This is a heavy burden on the practice, on everyone. Be cognizant of the procedure cost, the cost of atherectomy devices, DCBs, catheters. Opening 2-3 atherectomy devices for an SFA stenosis is not, that will take away from the other 9 patients that are waiting for the procedures. Be aware of the procedure time. Someone is tracking the cases, whether you know it or not. Understand that the payer mix that is local. Remember, value is the quality and outcomes divided by the cost. If your cost is very high and your procedures are costly, you're not adding a lot of value to the system. To the patient, yes, but not to the system. And to keep it sustainable, it has to take that into consideration. Be involved in benchmarking, whether VQI or the Outpatient Endovascular Society. Have mentors, have a speed dial, and I still do it frequently. And I would say find your niche. The vascular community practice is a broad term. Working in the community, you would want to be knowledgeable about everything, and you would want to have the skill set to do everything, but have a niche that really differentiates you from, and it will help you get better with what you do. For example, my 60 to 70% of my practice is CLI, so know the stakeholders that really take care of CLI patients and try to put a team together wherever you go. Dr. Shishehbor, I think, published in this expert statement that a lot of the stakeholders are involved between podiatry, vascular medicine, vascular surgery, cardiology, wound care. Work with them very closely. If your passion is AV fistulas, the nephrologists are going to be your partners. Marketing, disseminate your knowledge. There's a lot of disease. The burden of disease is very high nationwide. Deliver your skills, organize and attend local conferences where you are, organize CMEs, be involved with the media. Don't be afraid of that. Community practice comes with volume, so that may actually attract clinical trials. And of course, always be an early adopter of the new technology. Thank you.
All right, thank you. Next, all the way from Japan, Dr. Iida is going to talk to us about some wire choices.
So can I have my slide, please? Okay, thank you very much for having me here. So I'm Osamu Iida, interventional cardiologist. It's my great honor to present the extremely case, the CLTI caused by non-atherosclerotic etiology undergoing revascularization. Here is my disclosure. The patient is a 79 years old male who presented the non-healing ulcer. On his right, he classified Wi-Fi class W3I2FI1. He was diagnosed with scleroderma in 2013 and has been taking a steroid, Bosentan. From the 2016 to 2021, he experienced a recurrent cycle and exhibition the remission of the ulcer on his right foot. In 2021, he underwent a below-the-knee amputation on his left leg due to the failed angioplasty. So in this session, he had a non-healing ulcer on his right heel, which is resistant to the medical therapy. The patient ADL was ambulatory with use of the prosthetic limb. At that timing of the hospitalization, black necrosis was observed in the patient right here, so indicating the considerably high risk for major amputation. The ABI was immeasurable, and the skin perfusion pressure was around 30 millimeter mercury, indicating the insufficient value for wound healing. So duplex ultrasound reveals the posterior tibial artery, the dorsal pedis artery, and the pedal arch were completely occluded, while the plantar artery had a severe stenosis. So the clinical challenge of this case is shown here. This case was CLTI due to the non-atherosclerotic etiology. Contralateral leg was amputated because of unsuccessful wire crossing the IP and the IM CTO lesion. See, he had a non-usable vein, diameter of the saphenous vein graft at 2.3 millimeter, and a non-healing ulcer here. Anatomical severity was glass IP grade 4 and IM grade 2. So based on our experience of if endovascular approach is selected, revascularization for the posterior tibial artery to the canonical branch is mandatory for achieve the complete wound healing. So here's the initial angiogram. So ipsilateral antegrade common femoral approach was selected, and 5 French destination from Terumo was placed as the P3 segment. Similar to duplex ultrasound finding, posterior tibial artery was completely occluded from the ostial, and the inframalleolar artery were occluded. So we decided to establish the bidirectional approach to achieve the successful wire crossing. So lateral tarsal artery, which originated from the dorsal pedis artery, was connected to the lateral plantar artery. So we use this pathway in the retrograde fashion. We are able to advance Asahi SAW03 wire, which has recently been approved for peripheral use in Japan, through this channel with ease. This wire has a potential to revolutionize endovascular intervention, particularly in the treatment of the tortuous arteries, as it has a tip load of just 0.3 gram, making it the softest and the lightest tip load among Asahi guide wire. It improves the shaft design, enabling outstanding trackability and crossability in even severely tortuous arteries. The SAW03 wire was accompanied with a Golzar microcatheter was successfully advanced through this channel and reached the lateral plantar artery. So we conducted the intentional subintimal tracking using the baby J-tip wire, hydrophilic coating 0.35-inch guide wire, supported by CXI catheter. Similar to SFA intervention, we believe that the subintimal approach is a standard revascularization technique under the bidirectional approach. So this technique should be applied to BTK revascularization, because loop wire technique is a low risk for wire perforation and achieving the outside of the vessel. So we successfully conduct the wire rendezvous. After successful wire crossing, vessel diameter was evaluated by IVUS. So vessel diameter of the distal posterior tibial artery was 3.0 millimeter, while the proximal side was around 4 millimeter. The lesion was fully dilated by 3.5 millimeter Jade 2 balloon with nominal pressure. Here is a completion angiogram. The posterior tibial artery to calcaneal branch was successfully restored, and wound blast at the heel was observed, which expected to accelerate the wound healing. So lesson I have learned from this case, so wound-related arteries should be selected based on the angiosome concept. especially the significant wound. So how to establish the bidirectional approach is a key for success. Looped wire technique is a safe and reliable for treating the CTO region. I think the IVUS tell us the accurate vessel diameter. Thank you for your kind attention.
Nice case. Osamu, what size sheath are you? I'm assuming you're Antegrade?
5 French.
5 French? It would fit the 035 catheter and the other wire?
4 French micro, 4 French support cast.
Oh, okay, it's 4 French. Okay,
Thank you.
nice. Next, we have Matt Bunte, right? Yeah. Going to talk about reentry. And this is why retrograde access is so important. It not only increases your chances of crossing double, it's actually more than double because you can use antegrade, retrograde techniques that he's going to show us now.
Great, thank you. Thanks for the invitation to present today. So I'm going to present a 68-year-old gentleman with multiple forefoot digital ulcers for a couple of months, rest pain in the left foot that has increased over the last 6 weeks, tobacco, CKD3, he's had bypass, his EF is 25%, so he's high risk, and we vein mapped him, he has no SVG for bypass, no X-ray is negative for osteomyelitis. This is actually a partner of mine, so our vascular center is unique in that we have 4 vascular surgeons, interventional cardiologist, partner of mine, and then 2 IR docs that work in our vascular center. So this is one of my IR doc partners. And he called me up and said, hey, I've got a good case that I think we should double scrub on. And I said, I'm glad to. I'll order the pizza because this looks like a long one. And so you can see there's basically flat PVRs and really no detectable ankle or reasonable toe pressures bilaterally. And you can see on the duplex, I kind of arranged the images anatomically, but you can see at the mid-left SFA, there's kind of a pre-occlusive spectral broadening on that Doppler, and then there's just nothing, and there's kind of bidirectional flow in the popliteal, and then really nothing in the tibials runoff. Here's the aortograms. You can see the long CTO in the left SFA that basically extends from the mid-SFA into the popliteal segment. And then there seems to be some reconstitution of a perineal that looks dominant and kind of becomes the common plantar, lateral plantar. Not sure if this is an anatomically dominant perineal artery at this point or if this is just a large medial communicating collateral off the distal perineal, but either way, it appears we have single vessel runoff with really ambiguous distal reconstitution and that huge collateral at the proximal cap. So the clinical challenge really here is crossing this long lesion, and to Art's point, we really struggled doing this case antegrade. So this was a 7 French up and over, a 7x45 sheath with a knuckled 035 stiff ankle glide wire that I was able to keep the loop fairly small. Dr. Banerjee stepped out, but he's always a proponent of keeping the loop small, and so tried to do that. The loop did enlarge towards the adductor canal into the P1 segment, and basically just was unable to reach. There was some reconstitution in the P2 popliteal artery, unable to reach that distal cap where there was some reconstitution. Dr. Banerjee, I just singled you out because you were on my shoulder during this case. I know how you love to keep the loop small, and we talk about that a lot when we do a peripheral CTO. So I had created a large loop, trying to muscle my way through this lesion with an 035 system. So I exchanged this out, this stiff ankle glide wire out for an 018 Treasure 12, trying to point and shoot and re-enter, and just was not able to get in. So used IVUS on this case to kind of figure out where I went wrong, and it turns out I was pretty much subintimal the entirety of where I crossed. So I regretted using that stiff ankle glide approach. You can see on that IVUS that basically I get out pretty much right away. So spent a lot of time trying to go back to the proximal cap and rewire using an 018 system, and by that time I had created that huge loop, and then I also had that huge collateral, which is potentially problematic for perforation or getting entry into that. So essentially needed to use this distal tibial axis to complete this case. So went sheathless with an 018 Navicross catheter, and then a 014 Command ES, which is kind of my workhorse. Art, you mentioned you use the V18. I tend to like the 14. It does loop really easily, knuckles really easily, and then the tip of the wire is really durable because it's nitinol. So I was able to shorten the base of operations to basically the P2 popliteal artery. It's the lateral behind the knee look. So I've got an Antegrade Treasure 12 and Navicross and a Retrograde Command ES and an 018 Navicross. Retrograde wire was removed, and there's I like to aspirate, and if there's no blood, it often means you're not in the artery, so there's no point in injecting because you're just going to stain the adventitia. Took orthogonal views with antegrade angiography, and so this was the lateral. I didn't see much here, but clearly both wires are out of the artery. You can see I started to escalate here, and now I'm using Estado 30s from above and below to try to overlap, thinking about balloon facilitated reentry here. So I was able to overlap the wires, but again, both wires are out of the artery. There's a lot of collaterals going on right here, so potentially problematic depending on where you inflate. And essentially tried to do a reverse CART, so placed a balloon antegrade where there was a bit of overlap, and wasn't successful in reentering. The other way you can do this is take a balloon from below and do a CART technique. Parallel balloon wasn't possible because I couldn't get two balloons to get side by side, but that could be another way to do this. Eventually crossed this with facilitated reentry with an Outback. So you're in the subintimal space, your wire is not reentering, so you replace with a needle and enter the true lumen, or in this case, I entered into a retrograde balloon and then externalized the wire out of the foot. And there's basically three ways we can do this. We can use the Pioneer from Philips, which is ultrasound guidance. The needle on that device is a little shorter than the Outback, which is what I used here. And then there's the Enteer device as well. So long story short is that was the ticket. We were able to externalize the wire out of the true lumen within the foot, and then it was a matter of stenting this. There was a large amount of adventitia and not extravasation, but just a lot of adventitial staining, and really tore up that P2 popliteal segment. So ended up, because I was concerned about aneurysm in that area, put a Viabon and then lined the Viabon with a Sapera, just because of the flexion at that point in the leg, and then used Alluvia drug-eluting stents above that, basically to the proximal cap, and then had to extend the stent below the Viabon down into the P3 popliteal. There was still a lot of subintimal injury under the popliteal into the TP trunk, so extended drug-eluting stents. I was concerned, obviously, about the patency of this, but I felt like we had a really otherwise angiographically nice result, so I had the benefit of a lot of follow-up on this patient. So here's pre-intervention, 1 month post-follow-up. This is January 2022, and then the fourth panel is 4-month follow-up. ABIs are still 0.7, 0.8, and then just recently followed up in April of this year and has actually done quite well. So he had definitive foot surgery and ended up losing the hallux, but healed promptly, and he's continued to do well. So Dr. Banerjee probably was going to talk about his percutaneous CTO algorithm. So here it is. Definitely needed a hybrid approach. It's a very long lesion, ambiguous proximal cap with suboptimal target. Distally, a cap morphology. This was probably a type 2, I guess. It was concave, but a lot of complications with heavy calcium and involvement of the distal P2, P3. So I think the most important thing is for antegrade wire escalation, keep the loop small. Orthogonal imaging and facilitated reentry can really help improve the efficiency of these cases, and a dynamic approach where you're always thinking about, okay, if this doesn't work, what's my next step going to be? That really helps save time, contrast, radiation, and keeps your staff engaged to complete the procedure successfully. Thank you.
Great case. Hey, Matt, real quick about that case, just something to think about. So when you did CART from above. So what I might have done is reverse CART, so I don't make that dissection plane really large. If it crosses, then great. Or try to rewire and get closer.
Yeah.
The other thing you can do, could have done, is just re-enter into that island of reconstitution and then taken the true lumen a little further and then continued.
Yeah.
But just think, if you do CART, if you balloon that dissection plane, sometimes it can be very difficult to re-enter because you just made that space potentially bigger. So when you plunge the needle, instead of needle going into the balloon or whatever, it just pushes back, especially if there's calcium.
Yeah.
So just a thought.
Yep.
Congratulations.
Great. Thank you so much, Dr. Bunte, for that great
We had
talk.
a couple of comments over here.
Oh, where?
Right here on the right.
Oh, okay. Yes, actually, I was going to have them pull up your slides and see if the panel had comments
I
too.
just
Yes.
wanted to say congrats. That's a tough-looking case. But you know, sometimes you get into these situations where you're hours in and you haven't gotten connected yet.
Yeah.
And I think it's okay, and we take this from our coronary counterparts, CTO operators, to do an investment procedure.
Yes.
When you're really tired, your staff is tired, you know, things are not going to go well. And I think it's okay to say, I'm going to bring you back. And I think in situations like that, we all have to learn what our limitations are. And I've done it myself, where I say, I'm going to fight another day.
That's a great point, Dr. Lee. Yeah, and it's definitely an appropriate strategy to take to first do no harm, right?
One tip for the audience, when you're puncturing a balloon, sometimes, again, it can get a little challenging. We kind of tend to really crank that balloon. But a couple of tips for that is use an 014 balloon. Is going to be a little bit thinner, and don't inflate it a lot. You know, you don't want to take this up to 10, 20 atmospheres or 10, 12 atmospheres. It's very low, two or three atmospheres, so the needle doesn't bounce off of that balloon. And you kind of want an oversized balloon a little bit, you know, like 3 or 4 millimeters, depending on, or if it's an SFA, like 5 or 6 millimeters, and just very low pressure, as you know, just so that you can puncture that that balloon just to re-enter, or also just kind of keep sliding off of it.
Right.
And then just a really long wire, and then when you put that hydrophilic, I usually use a hydrophilic wire like you would, like I usually use a whisper, and then I really kind of jam it in there, and then kind of like just have it loop, and then as you pull it out, you have that link to go with it. So.
Great, thank you. Yeah, that's a great point. I too have learned the hard way that it's often better to, when you're puncturing a balloon, to go low pressure, and you can actually inflate the balloon then while the needle's on it, and sometimes that'll pop it too.
So I've noticed you used IVUS, and it changed your strategy. How often are you doing this?
A lot more, yeah. I mean, this was really a pivotal case because I thought I had, I was pretty true lumen man. I thought I had this thing, you know, pretty true lumen all the way down to the P1 segment. I clearly got out right away. And so I did spend a little bit of time trying to re-enter up top, and then I switched gears when that wasn't working, and then quickly went to facilitated re-entry.
Yeah, I would encourage everyone to use IVUS almost routinely.
Yeah.
I know the reimbursement issue and all that stuff, but it changes how you do things almost 2/3 of the time.
Yeah, and
from vessel sizing to how you enter the vessel and all kind of things.
And it helped with the distal outflow too, because I was back and forth based on the angiographic appearance of the TP trunk, but it was clearly not looking good on IVUS, and just I think I got a much better result, and to the fact that he said patency now for over a year and a half. It's good.
Great, thank you so much. If the media people would pull up Dr. Lee's slide, I want to ask quickly of the panelists over there, in these cases with challenging CLI, do you guys routinely get a preoperative CTA, and do you always prep the foot? Because one of the most painful things is to prep the foot in the middle of the case, which I did just yesterday. So just like yes, no question, CTA, and then do you always prep the foot? Shamas, Dr. Shamas?
Always prep the foot, and CTA if there's bad femoral waveforms or pulse.
CTA and prep the foot when I expect trouble beforehand, because you can probably tell from the anatomy this is going to be a complex case. You start getting ready for it.
Yeah, I agree. I mean, prep the foot if you think you're going to run into issues. In terms of diagnostic imaging, I just use it for access, not for diagnosis, mostly for access. So femoral pulses are down, I'll use it. Otherwise, I'll use it to see if I can go antegrade versus if I would need to go across over.
Yeah, I never get CTA unless they have crazy surgeries that I don't have records on. So if I do a duplex on it, I do a duplex on everybody. If I see the femoral is open, but blunted waveforms, then I'll go radial and shoot from above. But I don't use CTA much, but foot prep on everybody who has critical limb.
Great. Okay, so our last talk is a great case. Dr. Lee always has great cases. So Dr. June Lee is going to give us a case of SFA popliteal. I could not cross with antegrade approach.
Thank you. So I changed the title a little bit. Could not cross antegrade or retrograde. These are my disclosures. As I said this morning, I'm also very passionate about limb salvage. So the reason for our presentation, a 79-year-old guy with critical limb ischemia of the right lower extremity. The background history is that he had a CABG before he came to me, and that was about a couple of weeks prior to coming to my clinic. He had a lima to LAD and a free radial artery to RCA. He unfortunately had a pericardial effusion after the CABG was completed, had a re-exploration. So we already know he's kind of a sick guy. He developed a large bullae to both feet, actually, on the anterior aspect, the dorsal aspect. The left lower extremity healed successfully, but then the right lower extremity remained non-healing. I'm sorry this picture is a little bit fuzzy. I was actually trying to find a good picture of him, but this is from his wound pictures, so they're a little bit pixelated. And here you can see on the ABI, TBI on the right side of the screen that the dorsalis pedis ABI was 0.59 with a toe pressure of 0.3. So we knew that he likely had a fempop lesion that needed an intervention to promote healing here. And when I took him to the cath lab, first of all, he has the artificial knee joint, which always makes my day exciting. So on a very orthogonal view, you can see here that the popliteal P3 segment is 100% occluded with reconstitution into what appears to be the peroneal artery, and the anterior tibial artery is also occluded proximally. There's some reconstitution of the distal AT faintly via the peroneal artery, and essentially nothing much going on in the posterior tibial segment. But in him, angiosome guided should be the anterior tibial angiosome. So I'm going to turn to my panelists because I do only have one case, but we're trying to finish by 5 o'clock. All right, Ben, how would you approach this CTO? Don't say surgery.
I would probably be coming antegrade from the right femoral artery. I would be trying to get actually I love the Glide Gold wire for these. So that would be my first choice 018 system to try to cross this, and probably have a low threshold to come from the DP as well.
Okay. Others?
So is that, I'm just trying to understand the anatomy there. So is that the popliteal and then it gives rise, is it posterior tibial,
Yeah,
is the peroneal the dominant?
it's a very orthogonal view because of the knee joint. So this is coming from the LAO perspective.
Yeah,
so there's a P3 segment occlusion with a blunt cap.
Okay.
And then it reconstitutes what appears to be the TP trunk, and then there's a peroneal runoff. The anterior tibial is occluded.
Yeah, so I think I usually just go for the low-hanging fruit. And so although the angiosome concept is helpful, the peroneal is really the lifeline of the leg and lifeline of the foot. So the peroneal is going to give off your communicating arteries to the posterior tibial as well as the dorsalis pedis artery. So here I would probably go retrograde peroneal access. You're going to have a hard time. I would definitely put a catheter in antegrade, but you're going to have a really hard time antegrade because of that collateral that's coming off right at that distal cap, because that distal cap is the proximal cap. That's a hostile proximal cap. It's got an angle to it there. It gives off the collateral. So I think retrograde peroneal access would be helpful here.
Would you be concerned about jeopardizing that peroneal that is supplying the only collateral to the foot?
No, that's what I gave my my pedal access talk. And so, I mean, you definitely want to know. I'm not really concerned about jeopardizing the peroneal because, as long as you have good meticulous technique in getting access and not dissecting it and, just having a very free wire as soon as you get access. My only concern would be if you don't cross it successfully, I usually use the 018 quick cross, but when you get out, you want to be really careful that you don't cause compartment syndrome. So you just have to be sure that you're going to be able, or, confident that you'll be able to cross that CTO so that you can then come antegrade and balloon tamponade your access site.
Yeah, I think I probably would go DP. I'd open that AT anyway, but I'm not sure in the angle if that's a proximal AT, small island of opening. Is that an AT in the left frame?
Yeah, there's a small island of AT.
So you could potentially, this is one of the rare cases where you can get potentially a free shot, just stick that, open that proximal portion of the pop, stabilize that perineal, and then you could stage them and bring them back and open the AT in a separate setting, potentially.
And getting the sheath if you're coming from above, getting the sheath as far down as you can to give yourself support there.
Would you start with an ipsilateral approach or contralateral approach to your sheath?
So this is actually the trade-off of not getting a preceding CTA. I love living on my toes, so I almost never get a preceding CTA. But you also run into this issue where there is no pre-procedural planning, so I was up and over from the other side.
So do you get duplex?
I did not. I did not.
You do not or do?
I did not.
Oh, okay, but not routinely.
This was a relatively urgent add-on. His foot was not doing great, so we actually ended up bringing him to the cath lab like within a couple of days. So I didn't.
I don't think that's unreasonable. I mean, if it's critical limb ischemia, I mean, it looks very clear that it's critical limb ischemia. You need an angiogram. If you have a popliteal pulse, you know it's gonna be all below the knee stuff. So I don't think I mean, you could go straight to a diagnostic. It's sort of like doing, getting a stress test prior to doing a STEMI, coronary STEMI, where you know what the diagnosis is.
But I think it's different because, at least for my partners, there was the same mentality. Stress test versus taking them to the cath lab, the story's good. My reason for doing duplex is I know my access site, where the disease is. I sign them up for trials, SFA, DCB. I sign them up if I know it's SFA disease. And I know my access points, if they're open, closed, how calcified they are. So for me, it's every patient that goes, no matter how urgent, even if it's the same day, I'm getting a duplex because I'm in the office. So, Right. Right, I know. There's more red tape. Yeah. Right.
Yeah, realistically enough, I'm actually waiting out like 3 weeks for any duplexes that I schedule.
And you can also do your ultrasound right there in the cath lab, and just right there, and you can check the access and go from there.
And you mentioned the physical exam. I mean, if they have a popliteal pulse, I'll stick them. I flip them on the table, stick them Antegrade. I just make sure my pressure looks like the systemic pressure, and I don't worry about inflow. I just work on, I use the micropuncture. I do my diagnostic with the micropuncture, and then I kind of know what I'm putting in.
All right. So all great points. So just to keep us on track here, I went Antegrade first. Unfortunately, it was a very ambiguous reconstitution in the distal segment. So I switched quickly to retrograde. So to Shirley's point, I actually upfront prep all CLTI patients in terms of their foot so that we can just open the drape and go retrograde quickly. So from a retrograde standpoint, I obtained ultrasound-guided access into the anterior tibial artery. You can see this and I'm sorry for the knee prosthetic, which actually made the angiogram very bright, but there's a really steep 90-degree turn from the anterior tibial into the popliteal, so making it virtually impossible for me to penetrate the distal cap. So at this point, I took an angiogram. So from the top, you can see I'm subintimal in the P3 segment. So I decided then to get into the peroneal artery. So I actually traditionally use fluoroscopic guidance still for peroneal. We actually accessed into the vein first. So I left the wire in the vein. I punctured around the wire. I did an angiogram just to confirm my arterial stick is right where I anticipated it to be. We were fortunately able to get into the peroneal artery. But the wire kept traveling, actually, ironically, into the anterior tibial artery. So this is a technique where I mother-daughter a 018 microcatheter inside of a 035 microcatheter. So there's a 035 Navi that's about 65 or 90 centimeters with a CXI that is kind of mother-daughtered inside it. And then that way I can wire escalate into a 035 if needed. So brought a nuclear weapon, 035 stiff angle glides from the top and from the bottom, still not able to connect into the P3 segment. So I ended up doing something that I haven't really done before in this case. This was electrocautery it's called ECART, to essentially burn a little hole in the subintimal space. This was using a Connect 250T along with the little bovie on the back end of the wire. As my vascular surgery fellow buzzed that we were able to penetrate into the subintimal layer and into the P3 segment in a true lumen fashion.
Wait, could you explain that one?
Yes.
I've never heard of that before.
It's called ECART. So essentially, I would use a bare wire, so meaning like a Connect 250T that isn't jacketed, so it doesn't burn the jacket of the wire. And I have the stiff wire pointing directly at the intimal layer where I'm anticipating to push, essentially what happens, our colleagues in structural heart use this all the time to cross PFOs or to cross the septum. You burn it to essentially create electrical kind of burning of that layer on the very end of the wire.
And you hold it too?
Yeah, so the Bovie just hits the end of the wire. You turn it on, 2 seconds, it's gone. Yeah. Yeah.
Does it hurt the patient?
So if you're burning a space that is not correct, this is going to hurt the patient. I tried it in a different patient, and it didn't really work.
Doesn't it heat up the entire wire?
It does. It's actually like 2 seconds, so it's protected inside a microcatheter. So only the heat that is at the tip is delivered to the patient, not the entire. Exactly. Yeah, it's protected inside the microcatheter. But I would say, I've tried it in another patient. I would say it only really works when you have a very thin layer of intimal to kind of penetrate through. Kind of similar to a PFO. Yeah, exactly.
But it's hard to beat success since probably you got it done. The question, I noticed where you were in the perineal, you went into the AT, right? Why wouldn't you just use a reverse CART at that point right there? So just dilate that angle and just go with the wire retrograde where the balloon is, and then you can avoid that sharp bifurcation. Then you could go straight into that, distal popliteal.
Yeah. That would be another method. I didn't have a sheath. I didn't have a sheath in the AT though. So
Burning is cool.
I was sheathless in both tibials, so I didn't have a sheath to put a balloon through. But that would be another idea to divert that angle.
I mean, the other thing.
Sheathless for all of my interventions, people, like even for balloon angioplasty, I'll do it without a sheath, just bareback it like a overlay.
Could you just mention a second, how do you handle, you've made the point several times about how you handle your puncture site.
Mm-hmm.
So how do you do it, and how do you do it at your puncture site downstream?
So the peroneal is unfortunately not a compressible area. And you can see in this third image here, I actually did balloon tamponade of the site. Because remember, I sized up to an 035 microcatheter. So in the peroneal or in the prox AT, I typically do balloon tamponade. And sometimes I actually add on the external compression with a blood pressure cuff, just so it's, I do 5 minutes at a time. 5 minutes, and then recheck. And if I need to do it again, we're going to redo it. Fully anticoagulated. The external pressure actually sometimes helps with the efficiency of hemostasis.
Do you test when you let the balloon down that you got hemostasis?
Yep.
And if you have extravasation, what would you do?
Balloon goes back up. Same, I leave the, exactly, 5 minutes at a time.
Yeah, and I usually see, even if I have just like a little oozing, I just let it go, honestly. Because usually by the time you're...
Oozing from the skin, not extravasation on arteriogram, you mean?
Huh?
When you say oozing, do you mean arteriographic extrav, or do you mean?
Angiographic phenomenon, I mean, what you're doing is when you do that angiogram, you're also injecting with high force contrast, so it may look like an extravasation, but, practically speaking, it's just an ooze underneath the skin. But usually what I'll do is I'll do the balloon, just because, and the reason I do that is because inevitably if I just do external compression, inevitably at the end of the case you'll do a little angiogram, it'll be a little hazy. Usually it's just like a little spasm or anything anyway, but then you get a little stressed about it, then you end up doing balloon anyway. So I just do balloon for everybody. Same thing, like 3-4 minutes. Usually what I'll do is I'll go up until I see cessation of blood flow, then I'll stop and I'll sit around, we'll have some coffee, we'll hang out, we'll sing some Indian Bollywood songs.
But you do the same for AT, DP, PT, you use balloon occlusion for everybody.
It's probably most important for perineal,
Yeah.
just because it's non-compressible. If it's a PT, AT, you probably don't need to.
Only the,
But definitely don't reverse the anticoagulation and then go with the balloon, because you'll clot off that artery. And if you don't go across, I've had one case that I couldn't cross with the perineal. The blood pressure cuff is usually fine, because the perfusion pressure is so low, because you didn't open it. The other thing, June, you could have done when you were in the AT, which you crossed the hard part really, you were coming into the perineal with the wire. If you kept that and just put a balloon around it to protect it, you could come down from above with that Outback and puncture into it and then exteriorize it. But you basically did the same thing with cautery.
Yeah. And I think the other component is if you do a sheath in the distal AT or distal PT, you could also include it with a TR band at the end of the case as well, just for more efficient lap turnover. Cool. So we rebuilt that 3 months later. He's all healed up. He did have osteomyelitis of the first digit, so that did undergo a amputation on the digit. So key learnings: when you first don't succeed, try again within reason. have a general CTO algorithm to fall back on quickly. My team knows that there's usually a few wires that I ask for, and have a segmentalized approach to your iliac, CFA, SFA, POP, tibial, and pedal CTOs. Know when to escalate and know when to reach for different equipment. And last remaining tibial, it's okay to use if you're experienced and you're comfortable with safe access, but really knowing how to obtain hemostasis is important. Thank you.
Right, thank you very much to all of our speakers and our panelists. A really great discussion, lively discussion as usual. I'll remind everyone that we have the fellows reception right now, if any fellows or non-fellows want to go. And thank you, and we'll see you tomorrow.